So good evening and welcome to all to our third updates meeting. We hope to build upon our previous discussions to generate a shared understanding of the pressures in our system. I'm Sarah Benyon, I'm a consultant plastic surgeon and divisional director at CUH, and I'm joined tonight by a number of colleagues from CUH and also from CCG Primary Care in the South Alliance. And I'll just go around and do a few introductions now. We've got Dr. Ewan Cameron, he's a consultant gastroenterologist and our interim chief operating officer. I also have Hugo Ford, who is a consultant oncologist and divisional director for Division B, looks after Director of Cancer Services and Outpatients. I also have Vaz Ahmed, who is our consultant in ED medicine, as well as emergency care lead for Cambridgeshire and Peterborough STP. We've also got Amanda Cox, who is a consultant neurologist and deputy medical director, as well as Rachel Fenner, primary care liaison manager, Steve Hampson, who is assistant director of the South Alliance. I also have Jessica Borden, who is our director of primary care, Cambridgeshire and Peterborough CCG, as well as James Morrow, GP and co-chair of the South Provider Alliance. We are also going to be joined, we've got him, James Wheeler, who is just joining, and he is one of our consultant surgeons and also divisional director for theatres and critical care at CUH. And we also have Nikki Barnard, who is our business manager for CUH Comms, who keeps us all in check and makes sure we do this as well as we can. So thank you to Nikki and everybody else on the panel. I think at some point we should be joined by Dr. Rowan Burstein, who is a consultant in anaesthesia in an ITU, who will be talking on long COVID, but she's not currently with us, but we'll get an update on that as she joins us. So I guess with that, we'll sort of start the evening. We know it's a really poignant time to come together, as we all know and feel a real huge pressure across the system. And all of us and all of our staff are really feeling it. You know, from a CUH perspective, we've had the busiest June on record in our ED department. And, you know, we continue to struggle with capacity and with beds on a daily basis. And our waiting list for surgery, for diagnostics and outpatients really reflect a sort of growing trend. And hopefully by sharing our current situation, including pressure points and our plans and approach moving forward, that would be really helpful to people on the call. I also really know from discussion with my friends and colleagues in primary care, it's never felt so difficult. And, you know, patients are presenting with much more complex pathologies. There's a significant increase in mental health concerns with a reduced provision of services. And as well as all of this, there's all the huge work that you guys have undertaken with the National Vaccination Programme, which has really made it just so busy. So tonight we'll come together, as we have done previously, and hope to provide some key updates across the system. And we're going to start off in a moment with a general update of CUH from Ewan. Vaz will then outline and update how ED is doing and so the plans that they're making to take them forward over the foreseeable future. And we'll be followed by an update on our harm review process by Amanda. And James Morrow is then going to discuss the current situation in primary care and highlight some examples of how we can work together. We're going to finish off then with some specific updates on outpatients, cancer services, diagnostics and surgery at CUH. For those of you who joined us last time, we try and funnel all the questions through the Q&A box on the side of the screen, as we've done previously. And what we'll do at the end of each talk is have a couple of minutes for questions, but we'll try and keep most of them until the end. And we'll also try and keep active on the Q&A session and answer questions as we go along. And inevitably, if there's any questions that we don't get answered tonight, don't necessarily know the answer, Rachel will pick up and send out the answers to you all over the next couple of days. So with that, I am going to pass over to Ewan, who is going to start his talk on a general sort of overview of where we are in CUH. Thank you.
Thanks, Sarah. I think firstly, I just wanted to second what you said about the situation in primary care. I mean, it's really clear from the conversations I've had with the LNC, from with James and a variety of other GPs, quite how difficult it is in primary care at the moment. And I think, you know, we really understand how difficult it is. And clearly what I'm going to talk about is how it is currently in CUH, because I think it's probably fair to say it's pretty tough here at the moment as well. So perhaps if we just wait for the slides to come up. If you want to go on to the, I think the third slide, Nikki. That's it, lovely. So I think perhaps if I start with COVID, we've clearly had a very difficult period over the winter, but a much more stable situation over the spring and into the summer. We are seeing really quite significant increases in community rates of COVID, particularly in school-aged children and in university students. And we're sort of up to about 350 per 100,000 in the community. That isn't yet translating into a significant increase in hospital admissions. But we have gone through a period where between mid-May and mid-June, we had 3 weeks with no admissions, slowly increasing to admission every other day. And we're now running at about two patients being admitted every day. And that leaves us with a small number of patients. I think we've got 5 today, 2 of whom are on critical care, which we could do without, but is certainly much more manageable than we're seeing in other parts of the country. We're continuing to act in as COVID as secure way as we can, and we've got plans in place that would allow us to deal with significantly higher levels of COVID occupancy. Clearly, that would have an impact on the other services we're providing. So we hope we're not going to get to that sort of situation. The biggest problem that we're facing at the moment is the number of our staff who are off work, either self-isolating themselves or caring for children who are self-isolating. That's having a really big impact on how the hospital's working at the moment. Next slide, please, Nikki. So I think perhaps if I just, you've probably seen this before, but worth just reiterating what our recovery strategy is. And I think that the first priority is that we're trying to treat all of our P2 patients. Those are the sort of highest priority surgical patients within 28 days. And also concentrating on patients who are waiting very long periods. So 104 weeks is a very, very long time. We have a number of patients who are in that sort of ballpark at the moment. It's really important to us that we're focusing on the recovery of our staff as well as on service recovery, because staff have been through an awful lot over the last 18 months and we can't deliver any of our services without them. And then the last point is around plans to be able to respond to further waves of COVID, both in critical care and acute beds. Now, hopefully, vaccination will have done enough so that we won't face a very significant wave again, but we're planning for that if required. Next slide, please. Just very quickly talk about T2. We may have seen in the press over the last few weeks. So we've had some additional capacity built on site as part of the regional surge centre. This is the first of those facilities, and it gives us 19 beds that we're currently using for patients who are medically fit awaiting discharge. And what that does is it frees up capacity in the main hospital at the moment for recovery, but in the event of a further wave of COVID for treating those patients. Next slide, please. So what about waiting lists? Well, our waiting list has gone up by about a third since before the pandemic. It was obviously sizable before. Off that waiting list, about 30% of patients are patients who've been referred in the previous months, so sort of new entries to the waiting list. About 55% of the patients on the waiting list are still awaiting their first outpatient appointment. And whilst we are starting to have more patients who have treatments within recent months, those treatments are still below the number of referrals, so the waiting list is continuing to grow. And of note, we've got over 3,500 patients who've been waiting longer than a year for treatment. And it's probably worth saying, you'll see on the graph, the bottom middle, that appears to be going down. Some of that reduction is due to treatments, but a good part of that is due to reduced referrals during wave 1. So we will no doubt see that increasing again further. And although the black line on the graph looks quite striking, the numbers who are beyond 98 weeks are relatively small. They are growing, and clearly that's an exceptionally long time for patients to be waiting. Go to the next slide, please. So this is just some information that shows you how long you might expect your patients to wait to get treatments. So this is the 92% RTT. So that means that by these time periods, 92% of patients in those specialties will have had a treatment. And you can see that varies quite widely across the different specialties. So, for example, in neurology, it's 18 weeks, whereas in trauma and orthopedics, it's 74 weeks. And just to remind you that that information is available and updated on GP Connect, so it allows you to perhaps assist patients in understanding what their likely waiting times will be, and also, I guess, to think about potentially other alternative services if they're available. Next slide, please. So Sarah touched on this at the start. I mean, there's no doubt that we are seeing, as you are, a massive increase in non-elective demand. It's our busiest June on record. In reality, it's almost certainly our busiest month on record, because on top of these attendances, we have significant numbers of patients who are using alternative models of care, so same-day emergency care, who aren't going to the emergency department where they would have been previously. And I mean, Vaz will talk in a minute about the sort of pressure the department's under, but it's very substantial at the moment, and that amongst other things, that is resulting in particularly long waits for patients who are admitted, or waiting for beds in hospital. I think that's all I wanted to say for the moment. I don't know if there are any questions, or whether we just hand straight on to Vaz.
Thank you. I don't think there are any questions, so we'll move on. Nikki, thank you. So for what's that? I think Ewan has just mentioned, and I think Sarah mentioned at the start, the demand has gone well over what we were expecting. One of the things which we have noticed, and I guess you have seen in the news today, is that there has been 2.1 million contacts in emergency pathways. So basically just at emergency departments, and that has led to around 535,000 admissions throughout the country. So everyone is seeing the pressure, like you guys are seeing the pressure in primary care. Ambulance services are giving rise, the pressure in ambulance services is huge, and the NHS 111 pressures are huge as well. So I think everywhere the pressure has increased, and which has obviously led to an increased demand to into the emergency department and our emergency pathways, which, along with our exit block from emergency department, because of the number of beds we had to secure for COVID related reasons, but at the same time, the number of admissions which are going through our hospital has actually hamstrung us, and the demand is leading to long waits in the department. The next slide, please. So we've done quite a lot since COVID started. We were a single front door. We moved away from that to have assessment areas. We've done quite a lot, but we are continuing to do quite a bit. And I know Stephen is not here, and he would have said he leads the Urgent Emergency Care Board, and we've done some things about moving our ambulatory care into what we call as Clinic 5, which is next to our urgent treatment center. And that basically we're accepting now what we call a same-day ambulatory care patients. We also started doing booked appointments, which we've been doing since August, but we also started increasing the numbers of booked appointments to our urgent treatment center and minus as well. So we are seeing quite a lot of patients through there. We are also doing some video consultation through our HUC colleagues. So basically I've got 2 or 3 emergency medicine consultants who are validating calls in the NHS 111 pathways at the present time as well. And we also have some minor injury practitioners doing that. Our surgical assessment area has been a big success, I would say. The only problem at the present time, and the medical assessment area, but the problem is that we are facing what we call as exit block. We can't get patients out of there into wards, so the flow is kind of hamstrung. The ongoing challenges are, I've just mentioned, along with the exit block, the increased demand. And what we are seeing is long waits in the emergency departments because of the number of patients presenting between 4 in the afternoon and 9 in the evening. We are seeing around 35% of our patients, so probably around 100 to 150 patients between that 4 and 5 hours. Next slide, please. The numbers are important, but at the same time, we need to keep context as well. What we mentioned there, the NHS 111 ambulance and self-referrals have gone up, but those numbers are just a 4-week snapshot of where our busiest times have been ever in June. So I think that that kind of skews the data a bit. The GP referrals are interesting. It says that we've reduced our GP referrals coming to our emergency pathway. Now, Stephen and I think that this is due to one, because we are sending all these loads of patients to other areas. So we are not coding them as GP referrals in the emergency department. The second bit is while you guys are having so many contacts, patients are coming to us and we probably are not coding them right. So I suspect the GP referrals are at the same level or above of what it is from 2019. We're doing some work on it. So hopefully by the next time we'll have some more data related to that. We have done quite a bit of diverting activity. We used to see around 86% of our patients of the emergency pathway through the emergency department. Now we see around 68%. Thank you. As you can see, the activity, how it has changed from 2019 to 2021, and where we have spread our patients into SDEC, UTC, and UTC others, which is basically minus patients. So we've done quite a lot of work related to that. So we have seen quite a large increase in demand as well. As you can see, it's around 439 in June 2020. But June has been nationally and our largest month of attendance ever. So I think that's really important to understand. We are hoping that it would settle. Let's see what happens in the next couple of months. Next slide, please. So this is a sobering slide because we have our waits in June were around 3 hours and 52 minutes for patients who were discharged. That means they were seen discharged within that time, whereas our admissions were at 8 hours and 48 minutes for patients needing admissions. So our admitted patients are waiting very long. So are our discharged patients. So there is quite a lot of work going on to see how we can make the pathway much more smoother and make sure that times are reduced. But as I said earlier, this is the combination of two things: increased demand, exit block, leading to the no space to see patients within a constrained environment. Our pre-12 discharges have also gone up to around 14% from 12%. So that really helps us to get our patients out of the emergency department much earlier. The next steps. Tonight we are closing part of our emergency department because we are trying to rebuild part of a resus area so we can make it very COVID secure, so we can manage patients through there in a better fashion, and we can release our ambulance bay where we were seeing our COVID patients. So we can use the ambulance bay to do what it was supposed to do. That means receive ambulances. So that will really help us. But the work is going to go on for 8 weeks. So I think it'd be really helpful. And I think this is a plea from me to everyone in primary care. And I know you guys already do that, but these 8 weeks are going to be high pressure for us, especially with the space which is being available for us to manage our patients through. So if we can manage it in any other way, SDEC, ambulatory care, assessment units, and various other things, that's where we would like them to go to, please. So we have taken on an extended GP pilot, which I'll mention in the next slide. I've talked about the virtual consultation by emergency medicine consultants and minor injury practitioners. And I've also talked about the direct booking. These are things which are, we are trying to avoid patients coming into the emergency department. Just to be aware, last June 2019, NHS 111 saw around 23 to 24,000 patients. This June 2021, they have seen 35,000 patients. But what has remained flat is the conversion rates to the emergency department. But just because of the numbers which have gone up, we are seeing a huge increase of patients coming in. Ewan talked about the T2 and what's it? I've talked about the Clinic 5 and how we're going to try and manage that. And our surgical assessment unit, as I said, we got a consultant holding the phone, and which you can get advice from during the daytime, and after that it's the registrars who hold the phone. Next slide, please. Thank you. This slide is extremely important for us, and I think for you as well. These are all the numbers which you can access our services, and you probably can get advice. Not probably, you will get advice. So one of the things is that the medical consultant-led GP liaison line, which we had a pilot in April, but we've restarted it on Monday and Tuesday. I manned the line, and it was actually really helpful for us to control and make sure the patients are coming to the right places rather than to the emergency department, but also give advice to our primary care colleagues about what certain group of patients don't need to come to us, and after giving advice, keeping them at home and various other things. So we would really value some feedback over the next month or two with regards to this. Even though it says Monday, Tuesdays, and Fridays, the days were chosen because of the high numbers of patients who you guys see. So you needed, we thought that was the best time. And in fact, looking at the numbers, that were the right times to do. In saying that, Wednesdays and Thursdays, we still have a consultant available, but they're not dedicated to the phone. So if you ask and say that I need some advice, they will get you someone to talk to you directly. So please use those lines. The surgical line's been a big success, as you guys have fed back to us, and it still exists. And you have all the other registrars and other lines through the switchboard as well. Thank you. Thank you very much. I think if you have any questions, please put in the Q&A. I'll be available for the next 10 minutes or so. After that, I need to head off for my shift. I'm quite sure Ewan and Jess would take other questions from pre-hospital and intra-hospital if necessary. Thank you.
Thanks, Baz. I'll just come in there and just say, yeah, let's have as many questions as people want to put in the chat as possible, and we'll try and you know, come up with the right answers. And I guess, Baz, just from my own question for you is, you know, I suspect a number of people are surprised to hear that we are undertaking sort of work in the ED department when we're under pressure, but this is really the only time that you can do it. And I guess it's about preparing for winter, isn't it?
Yeah, I think what we did was we looked at, one, we are preparing for winter. We looked at trends from 5 years or so to see where our attendances would start reducing. And we thought this was the right time. And in looking back now, it is probably the right decision, because even though June has been busy, we have started seeing a slight reduction in number of attendances. So we are hoping that August that will happen, but we need to make this happen before winter. So we are COVID secure and making sure we can flow better through winter and manage a crowded emergency department. Yeah. Yeah,
no, thank you. Okay, so if there's any questions further for Vaz, please post them in the Q&A, and we can answer them as we're going along as well. We can type answers, so I encourage you to use it. So we're going to move on to managing the harm within our patient cohort, and Amanda Cox is going to come in now and discuss the process that we've set up at CUH.
Thanks very much, Sarah. So we're very keen to share with you how we're trying to minimise risk to our patients who are currently on waiting lists, awaiting either first assessment, treatments, or follow-up appointments. The harm review process has of course been embedded prior to the pandemic at CUH. We have always reviewed our 52-week waits and cancer breaches, but this is of course now a mandated process. There are lots of benefits to it, not least providing assurance that we're monitoring the patients on our waiting list, but also allowing us an opportunity to reprioritise patients where we do review them and recognise that they may be at risk of imminent harm or coming to harm, and to put together fresh management plans for them as required. The way it's conducted at CUH is that patients selected for harm review are sent as a list to the specialty. The consultant in charge of the patient or a member of their team reviews the notes, and if they're concerned that the patient is at risk of moderate or severe harm, they will contact the patient to have a discussion. If a patient is identified as potentially coming to moderate or severe harm, then that patient will go to a harm review panel, which is a multidisciplinary panel made up of a variety of clinicians, but also people from the operational team, for example, our Director of Elective Care, and representation from psychiatry, thinking about psychological harm, but also we have GP representation as well. And there the case is discussed, and if it is upheld that the patient has potentially come to moderate or severe harm, then there is a process of reprioritization of the patient, along with duty of candor being requested for the patient and a root cause analysis in order to ensure that within that specialty we look at where the delays have occurred and whether or not there are any other factors in addition to the long wait that's been made worse due to COVID. Thank you. And up to date, we have been really our patients selected for harm review have been guided by the national sort of guidance that we should be undertaking this at 52 weeks. When a patient's waited 52 weeks on an RTT pathway with different parameters for the cancer pathways, which are shown there. But the work that we've done to date at CUH, over 6,000 harm reviews over the last 12 months or so, we have found only a very small percentage of patients being identified as potentially coming to moderate or severe harm. And in some specialties, in choosing these cohorts, actually the harm identified has been much lower. And ophthalmology is a good example, whereas they've conducted approximately 10% of the total harm reviews at CUH due to their very long waiting list. But in selecting these particular patients, they found less than 1% harm. And so we're keen to review the patients that we're selecting. We're working with specific specialties to look at the cohorts that are waiting within the specialty and to look to select patients who have been waiting for shorter lengths of time, but perhaps have particular diagnostic reasons to be at higher risk or have been prioritized into a higher priority category. So since the start of the pandemic, all of the patients waiting or referred in for assessments or treatments are prioritized between P1 and P4, as I'm sure you're aware, with P1 being the highest priority patients requiring effectively immediate care, P4 being patients where it would be acceptable for them to wait 6 months, up to 6 months for their treatment or assessment. So a lot of our 52-weekers fall into the P4 categories, having been prioritised earlier on in their pathway. But we're concerned about patients who are P2 or P3 who have waited an excessive amount of time. So for ophthalmology, we're, for example, planning to shift to assessing patients in the P2 category who may have waited for 12 weeks for their treatment. We're also looking to identify patients who may be more vulnerable, so patients who are on waiting lists who have learning difficulties or severe mental health, which may mean that they don't get in touch with us or you when they may be coming to harm, because of course a lot of the patients will be getting in touch with us if they're concerned that they're deteriorating, or patients who are presenting to ED or contacting PALS to alert their deterioration to us. But we don't always capture all of this. And of course, patients will be coming to you, raising concerns about their long wait. And so we're quite keen to make it easy for you in primary care to get in touch with us if you are concerned about patients on our waiting list who may be deteriorating. And we appreciate that there are many different avenues to contact CUH. Patients may be waiting for such a huge variety of outpatient or inpatient treatments or appointments with all of the specialties that we have here. And so we've created a single point of contact, an nhs.net address to which patient details can be sent to us with a brief account of what they're waiting for and what the concern is. And we will then take that, look at it and forward it on to the relevant specialties as required for harm review to be conducted and for patients to be contacted if required. Of course, if a patient is deteriorating rapidly, we would ask you to follow normal process, contact the specialty directly, or send the patient to the emergency department if there is a concern about a very rapid deterioration. Finally, we would just like to invite anybody who is interested in being involved in the harm review process, or simply coming along to see what we do, or to speak about a patient that they're concerned about, to the panel. Please get in touch with us if you would like more information about coming along to the panel, or about the process at the harm review address at adambrooks.nhs.uk. And finally, if you have any questions, please again put it in the Q&A. Contact us later down the line via our email address, and I'll be happy to try and answer those and be of any help that I can.
Thanks, Amanda. That's great. And I know actually in the last update session about 3 months ago, we sort of highlighted the initial process that we'd set up, and you've obviously developed this hugely over the last sort of 12 weeks. In the last update session, we had quite a lot of interest expressed from primary care about being involved in this. So hopefully this will allow people the opportunity to both discuss their cases and also just attend the harm review panels and see what we do. And I think you've already had some uptake, haven't you? From various sort of external people from the system who have been attended. And I have to say that their contribution seems invaluable. I don't know if you've got anything you want to sort of add on that.
Yes, no, it has been very helpful to get both the perspective from primary care, from one of our CPFT psychiatry nurses, and members of the CCG, and similarly to listen to the difficulties in organising harm review in the community. There are many community-based services that are struggling to pull together similar processes. So I know that this is a process that we're all looking at to try and minimise harm, but it's definitely evolving and developing, and we'd really like to invite our primary care colleagues to be involved and to let us know if they have concerns.
Thank you. Okay, so that will move us on to James Morrow, who's going to talk to us about sort of what's going on at the moment in primary and acute care, and give us an overview of the current situation that's being faced there. So thank you, James.
Thanks, Sarah, and thanks, Amanda. I mean, it's very clear that we're all in this together as professional colleagues, and potentially indeed either ourselves or our family members as patients within the system as well. So what we're talking about is very real and very tangible, and something that we all bear a collective responsibility and accountability to do the best that we can. But as people already alluded to, the entire system and every aspect of it is under an enormous level of pressure. And I think that has been felt by individuals, by systems, by departments, and by groupings, that we all share that. And I think I was asked really just to give an update on what it feels like in primary care. Next slide, please. These aren't my comments. These are comments which were submitted to the local medical committee's survey of general practices done during the month of May. And these are direct quotes from 75% of all practices responded to the survey. So there's a good balance of input into this from across Cambridgeshire and Peterborough. And I think what comes across here is that GPs, colleagues across the patch, are feeling that things are at a fever pitch that has not previously been experienced in terms of demand and need. And I think concerns about the ability of many within primary care and practices to continue operating at the current level of intensity and demand. Next slide, please. And I think coupled with that, as highlighted here, is the impact on staff of working above and beyond the core base of general practice it's been the delivery of over 75% of the COVID vaccinations done within our area have been delivered by primary care networks, by practices, by GP staff to their patients. And that has been done on top of, not instead of, normal activity. And for many people, this has involved working weekends on top of the routine week. And I think what's also highlighted here is the increasing complexity that we've heard already about the increased waits for routine and urgent treatment, the number of people at 52 and 98 weeks. Those patients don't disappear, they continue to come into general practice, that we continue to help them manage their condition during this wait. And we're seeing increasing complexity of patients, higher levels of pathology, and I think right across the board, but particularly in children and younger people, a real torrent of mental health issues presenting very often in people, in families and children, in adults who have had no prior psychological morbidity, that this is really a de novo feature. Next slide, please. One theme which does emerge again from colleagues across general practice is the feeling that sometimes we're being asked to do things that could be done by other people, and that we're being utilised in an administrative or secretarial role. That doesn't help us, help the patients, or indeed help the system. It adds cost and complexity, the risk of transcription errors, and transactional costs. So that is a theme which emerges quite strongly from within the GP community. Next slide, please. The background to this as well, which I think it's important just to note, is that the number of GPs per head of population has now been falling consistently for the better part of a decade, and this is the first sustained fall in GP numbers for over half a century. Next slide. And this figure from a Lancet paper last month, or the month before last, really quite starkly brings out the circled bit, shows the impact within England, or the changes in both consultant numbers and GP numbers over the decade from 2008 to 2018. So we're seeing roughly a 30% increase in consultant numbers, coupled with a roughly 9 or 10% decrease in GP numbers. And here in Cambridge and Peterborough, we have one of the highest numbers of patients per GP whole-time equivalent anywhere within England. So the workforce is under pressure, is reducing in numbers. At the same time, we have a perfect storm of increasing demand and delays in, understandable delays in treatment and investigation. Next slide, please. There has been a popular conception or misconception within the lay press that general practice has been closed, that we've been doing nothing. This is NHS digital data for Cambridge and Peterborough for the month of April, published only a couple of weeks ago, that over 400,000 appointments were offered in Cambridge and Peterborough general practice in April alone. 57% of those were done face-to-face. That's nearly 1 in 4 of the population seen face-to-face in the month of April alone. 53% on the same day, 81% within a week. So general practice has been available, has been seeing patients, and in numbers which are higher than they have been in recent years. Next slide, please. On top of this, Cambridge and Peterborough in April alone, over 90,000 COVID vaccinations done in general practice settings by general practice staff. Next slide. Bringing it from the sort of general down to my practice, this is an illustration of the demand telephone consultations that we have been doing as a marker really of general demand across the practice over the last 12 months. And we've seen a 60% rise in activity over the course of the last year, and we are now running at about 145% to 150% of pre-COVID levels of activity, and we're doing that on a sustained basis and with what appears to be an ongoing rise in demand. And this week alone, we've had to add an extra 20 phone lines in our practice to help us manage the current levels of demand. Next slide, please. We're well familiar and we have fantastic data and evidence coming out of acute trusts and indeed to some extent community providers about the levels of demand and activity. Primary care by its nature has historically not done this. It's largely been anecdote rather than evidence. And the local medical committee, in conjunction with practices and with the help and support of the CCG as commissioners, have been looking into how we begin to capture some of the activity levels of general practice to provide a compatible scale, or at least a consistent run rate measure of activity and demand in practice. And borrowing from the hospital OPAL, operational pressures escalation level data, this has been developed by several local medical committees across England. Next slide. Which shows that over half of GPs or other clinicians are currently working at OPAL 3 or 4 levels, so either red or black alert levels, delivering between 36 and in some cases up to 70 contacts per patient contacts per day, a level which is deemed to be potentially unsafe or in fact unsafe. So the pressures on individuals and practices are considerable and growing. Next slide, please. So I think we're all aware of the pressures within practices, the pressures on the rest of the system, the emergency department, diagnostics, our ambulance service colleagues. We are aware of all of that, and our community providers as well. System leaders meeting a couple of weeks ago, the ask really was what could be done quickly to try and help primary care, not in terms of structural changes or long-term slow burns, but what can be done relatively quickly. And these were the 3 asks which came from system leaders for acute trusts, both in the north of the patch and the south. Firstly, to remove GPs from acting as simply secretarial post boxes to move referrals from one consultant or one clinic to another. Secondly, to remove GPs as simply, again, an administrative function in optometrist to acute referrals. And thirdly, to begin to open up again some of the ease of access in both phlebotomy and radiology. Real progress has been made in all of these areas already. They haven't been completely fixed, but as Hugo and others will be able to report, this is beginning to happen. Certainly we've got the drive-through phlebotomy at Newmarket already. Radiology is working on increasing accessibility. Optometrists, I think there are 10 optometrists who will be part of a pilot to directly refer in, and increasingly there's a program to facilitate consultant to consultant, clinic to clinic referrals within the trust. So thank you very much.
Thanks, James. I just wondered if any of the other panel would like just to sort of comment on those system changes that have been discussed, either Ewan or Hugo, just as James commented.
Yes, thanks, Sarah. Yeah, so look, we're really committed to trying to help, and in particular, it's really important that we don't generate work for each other in the system because everyone's under so much pressure. We will get the consultant to consultant practice change. There are some complexities for us in that we serve a whole range of other CCGs, and so we've had to get permission from other CCGs to do that. And what we also need to be careful that we don't drive secondary care activity from outside Cambridge into the hospital, because all of our services are under massive pressure. But we will get that sorted out. And importantly, what's not on that list is that we will re-emphasise the importance of our clinicians not asking you to arrange tests after seeing virtual appointments. So we'll work on that. The pilot for optometry is an electronic pilot, something called IERS, which, as James says, will be going live in 10 optometrist practices at the end of this month, and the plan is to roll that out relatively rapidly across the whole system. As James said, we've got the the drive-through phlebotomy at Newmarket Road, we will be losing access to that site at the end of the year. So we're working really hard to find an alternative, because it's important for you, but it's also important for us. And we will do what we can on radiology. There are obviously some issues relating to social distancing in the hospital, which creates us some challenges, but we're absolutely committed to helping on all or as many of those as we can.
Yeah, just on the radiology, we are very keen to have as much direct access as possible, but at the moment, with the current restrictions, walk-in anything isn't really possible. So, but we are going to look at how we can improve that and improve the efficiency of direct access for GPs to ultrasound and plain X-ray, particularly.
And I think from the primary care perspective, there is a real sense of genuine system working and collaborative problem solving around this, and going back to the fact that we are all in this together. It is a shared problem and a shared resource, and I think what we're really demonstrating the benefit of the relationships that we built through this forum and others in terms of engagement, shared understanding and shared problem solving, which is absolutely fantastic. And as we move forward into the ICS and the ICP, increasingly the South Alliance becoming the Southern ICP, that we will, I think, find it easier to create these shared solutions in a way which works better for patients across the board. And if we can do that, I think it will make all of our lives easier. So thank you very much.
Thanks, James. I think we'll just move on to Rowan, who's now joined us to talk about the management of patients with post-COVID-19 syndrome. So over to you, Rowan.
Brilliant, thanks, Sarah. I'll be fairly brief with this. It's a piece of work that has been ongoing since February, and is very much a piece of work that cuts across the ICS. It's a very collaborative project, and of course this is a very difficult patient group that is a new patient group for us. So we've been working, I've been working with NWAFT, with community services and with primary care to set up a pathway for these patients. Most of you should be, thanks, next slide, most of you should be very much aware of it. I'm hoping that our communications have got out and the pathway is certainly starting to very much to be used. Could we go back to the previous slide, please? So what we've done on the right is the entire pathway. I'm not going to go through it in any detail, but just to sort of make a few salient points about it. So it's up on the CCG website. The referrals that we take are only from Cambridgeshire and Peterborough. We have had some patients from outside our ICS referred to us, but there is a post-COVID assessment service in every ICS across the east of England. They're all funded. And it's really important that we don't have patients coming into us because we don't understand what the local services are that we are sending the patients out to. We are very much an assessment service. We're trying very hard not to send patients back to you because the admission is because the referral is incomplete, but we can't assess the patients without the adequate data to assess them on. And one of the critical things is that there is no other underlying causes that might account for the symptoms. And we would request that where you're worried about those patients, that they be referred into the specific services. There is a pro forma. I appreciate it's long. It's been written in conjunction with other GPs, and we've minimised it as much as possible. And we really need it to be completed for referral, not least of which because we have an enormous data return that has to go back to NHSE, which we can't do without that data. The referrals are only coming through primary and secondary care. We've got we have been requested for patients to self-refer, but because of the information that we need and because of our limits on the funding and the staffing and the service, we really can only take them through primary or secondary care. We're working on a secondary care pathway at the moment. It's a bit messy, partly because the two trusts work a little bit differently. The primary care pathway is working pretty well, I think. So basically what happens is the patients, you refer the patients with a pro forma, and once we're sure it's complete, we accept them into our system, and we send the patients out a fairly detailed questionnaire which talks about their symptoms and life impact. And the reason for this is they are complex patients, and it means that we've got a really good, we can have a very good focused discussion with them. So they're all assessed only virtually at this stage. and they all come into a single point of contact for that virtual assessment. So the assessment's undertaken by Band 8 and Band 7 nurses and AHPs and others, and then a decision is made on the next stage. As I said, it's a single point of contact. The complex patients, which is about 50, the more complex patients, which about 50% of that group, then come into an MDT, a virtual MDT that's attended by a wide range of clinicians and AHPs. We have people from IAPT, mental health, chronic fatigue and so forth. And we run that once a week and then work out where they go. And the whole idea is to try and keep these patients out in the community services and really demedicalise their issues insofar as we can. There is a definite and distinct group of patients who are really complex. It's about 30% of them, and they will come into a face-to-face clinic. At the moment, they're being held weekly or twice weekly in Addenbrooke's, and we're just about to start a second clinic up in the city centre in Peterborough from the end of this month, and hopefully that will evolve into a weekly clinic as well in due course. We make all the referrals we possibly can out of those clinics. We don't send them back to you unless we're absolutely necessary. And it's pretty infrequent that they come back with an action for GPs to do the referrals. Go out to the community, the relevant community services. Paediatrics is not part of our service, and that's in the process of being developed, and that's effectively, I think, a GP assessment into the tertiary centre. I know that's not up and running at the moment, but it's not far off. Our big issue, like your big issue, is that there has been, well, our biggest issue probably is staffing actually, but our other big issue, of course, is there has been no additional funding for community services. So these patients are waiting to see you, they're waiting to see us, and then we at the moment are putting them out into community services who also have their own waiting and priority lists. And so one of the next piece of work that we will be starting, I hope in the next few weeks, we're just pulling it all together at the moment, is to develop a much more bespoke program of care that we can move these patients out into. We're piloting that at the moment, and there is funding going forward for that. I think our big challenge, as I said, is going to be staffing. That again will be an online program, and we're just working out for the patients who need more than that, how we take that group forward. Other things that we're working on at the moment is the directory of services, which trying to make that as bespoke as we can for the long COVID patients. We're an exemplar project for the shared care record, so that's in very early days. And then we're developing, these patients really need a lot of links with social prescribers, care coordinators and so forth, and so we're trying to streamline those pathways as well. And finally, as I said earlier, trying to streamline the hospital pathways to make sure that the patients don't have to come to you before they come into this service, that we can find, we're working on a way to get them straight into the service if that's what's needed. Next slide, please. Have the next slide, please. So you, I'd hope some of you are aware from the NICE guidance, back a slide. Of the pathway for general practice, for which NHS England has just released £30 million. And if it hasn't come out to you today, it will certainly be coming out to you in the next day or two, a request for practices who have an interest in developing interest in the post-COVID assessment service. There is funding to help deal with the patients who are what we would call our less complex patients, so the ones who really should be able to be managed by self-management or a really clear referral into one of the community services. This is very early days for all of that, and we're very keen to work alongside the general practices that do get involved in that and help develop that service. I think it would be a mutual benefit for both for the more and we will then wind up taking the more complex patients. Next slide. Just to give you the next slide is just to give you a feel of the what the actual activity is. So we really properly opened our doors just after Easter. We've currently reviewed about 70 odd patients. This data's, I've only just got the data from last week today, so I haven't been able to present it, but we've seen, as I said, we've seen 70 patients. We've got about 100 patients waiting for assessment. So these are patients who have returned their questionnaire, and for that group, the wait is approximate somewhere between 6 and 7 weeks for that initial virtual assessment. If they do need to come on to a face-to-face assessment, we're getting them in very quickly, probably within the next week, 1 to 2 weeks after that. So that bit's quite works quite well. There's about 50 patients who haven't on our books at the moment who haven't returned their questionnaire. The type of patients are very typical of patients that are seen across all of these services. So we're seeing a lot of people in their middle years rather than the elderly. There's a preponderance of middle-aged women. Our data for ethnicity is very poor, and there is an underlying concern for all of us that we're not accessing all the people out in the population that we ought to be accessing. And again, a separate piece of work around working with patients, with the community to find other ways of accessing these patients and bringing them into the service. We're just starting to look at some outcomes. We haven't got follow-up outcome yet because we just haven't had time to do it with it, but basically using EQ5D scores. And then the final graph on the left, if I'd shown you the graph of where the referrals, this is a graph of where the referrals are coming from. 6 weeks ago, they were really only coming from around Cambridge. It's getting much, much bluer out towards Peterborough, which we're really pleased about because it means that the whole region is starting to refer into us. And my final plea, which I appreciate doesn't sit entirely well with what James has just said, is that we are absolutely desperate for staff to try and get this wait down for patients to be reviewed by us. We have got funding, but we really need desperate to have some more GP involvement in actually doing some of the screening sessions and working on the with us in the virtual MDT. The only fixed point of the week is Tuesday afternoons, which is where the rest of us meet for the MDT. And that's it. Thank you very much.
Thank you, Rowan. That was great. Obviously, I have to say, I was actually quite impressed to hear that your waits are only 6 to 7 weeks compared to most other services in the hospital currently. That is pretty fantastic, particularly for a new service. There was a question that Michelle Ralph had, and I think James wanted to answer it, but it was related to the North Attlesford patients not being able to access the system currently. James, did you want to come in there, or?
I was actually just typing your responses, but I absolutely agree that if we have patients who are under the care of CUH for all of their routine secondary care rather than necessarily tertiary or quaternary care, that it does make sense to maintain them within the system where they're known, which they're familiar with, and which their GPs have confidence. So I suppose really from the primary care perspective, a plea that there is an intelligent application of boundaries rather than a rigid application of boundaries. Again, coming back to the point that if it was you, your mum or your dad or your cousin, what would seem reasonable, sensible, right, logical and fair? And I think that's really just my plea, is that in all of these things, we do need parameters which ensure that we don't become overwhelmed or swamped, particularly a centre of excellence such as Addenbrooke's. But we also need to ensure that we don't disenfranchise patients who view Addenbrooke's as their DGH from receiving the services that they think they should obtain.
Yeah, no, thank you. So Rowan, this was related to the patients in North Attlesford not being able to access the post-COVID assessment service. And I suspect is it James, this is a Michelle, this is a postcode issue. Is that right, because of the CCG?
I don't know enough about the details of North Attlesford, but I suspect it is. You know, we run into problems in the north of the county with Oundle and Northamptonshire. We run into problems in Royston with Hertfordshire. And I think that this is something as we become a more functional ICP and ICS, that clarity around these issues. And again, coming back to the fact that if primary care networks, PCNs, are the building block, the foundation of the new 3-tier structure of neighbourhood or locality place at ICP, which is the South Alliance, which we're all part, and then system sitting above that, that we ensure that actually patients served by PCNs within the patch have equitable access to all the services within the patch, and that will mean some jiggling around of what were postcode boundaries, I think. But it's something that I think needs to be worked on, and absolutely we need to ensure that patients within our geography as an ICP have equitable access to all the services available within that ICP, even if they stray across a county boundary. And that particularly applies, I think, to community services and local authority services, which can be quite problematic at times.
Yeah, no, thank you. So we're all well cited on the issues for the cardiology patients, obviously, but for CUH from the patch, and obviously it's and you and I are very well cited on that. So this is obviously a problem for other cohorts of other diseases and other cohorts of patients, by the sound of it. So it's something that we need to consider moving forward. But thank you. Okay. On that note, I think what we'll move on to now is an update on outpatients and diagnostic services. And I understand this is going to be Christoph, who has Christoph Kastner, who is one of our consultant neurologists and also our clinical director for outpatients, who's going to give this update. Is that correct?
Yeah, that's me.
Fantastic.
Hello, everybody. And I hope I can give some reassurances with the couple of slides to present. First of all, what is reassuring is that the demand is actually not much more, and we're comparing ourselves now to May 2021, because obviously to May 2019, because 2020 wasn't really a real world. So it's about 98% of demand. But actually the demand we are far more concerned about, and everyone should really, is the demand on our waiting lists for follow-ups, which is quite considerable and still to some degree unknown. But our specialties have over the year or so done a huge amount of work to actually clinically risk prioritize all those waiting lists to allow us to allocate the resources we have to the right patients. So the main specialties we are concerned about are ophthalmology, rheumatology, cardiology, trauma and orthopedics, and dermatology. And then there's still others, but I'm just mentioning those to highlight. But those specialties have actually done a significant amount of work, are still doing that work. To start with, if we go to the next slide, thank you. To go to slide 43, what is really pleasing is that we actually managed to keep the absolute number of virtual consultations at around 4,000. And the reason why that's important is that we still work with a lesser room capacity, which isn't even that much affected anymore by social distancing, because we've been very good at managing the flow through our clinic. So it is essential that our clinicians continue to deliver a good degree of our care virtually. And obviously, and that continues and also is reflected by us of the request by James earlier, that we do need those off-site, almost walk-in facilities like phlebotomy and imaging, because without that, virtual consultations wouldn't be that possible. So we still work on that and on the provision also in the future. As already mentioned, the phlebotomy service, we are desperate to continue after November. So that is one. The other ways we are trying to support the services with and to address these high-risk, high-volume waiting lists is they are bringing locums in, we're doing weekend working, and in fact, we are optimizing the utilization of our rooms, sharing rooms, and also recycling rooms. And we have given priority to those specialties I earlier mentioned to use those rooms to work on those high-risk waiting lists. There are also one or two projects to look at insourcing, but they haven't really developed that far yet. We are working on it. But if you can look at here at this slide, we are delivering a good component of service virtually. But if you're worried that we haven't quite achieved the outpatient first 100%, please look a few lines down. We are probably, due to the risk prioritization, focusing more on the high-risk waiting lists of follow-up to ensure that patients remain safe. So please I hope you understand that we need to look at the clinical risk, and we have a good tool within our electronic medical records to deliver that. So I hope this reassures we're doing everything we can to get to 100% overall or more. Thank you.
Thanks, Christoph. I'm going to sort of take on and talk about diagnostics. So the main story with diagnostics is that we've had, with the increase in activity, a very significant increase in demand, particularly in emergency demand for cross-sectional imaging. So where we are at the moment is we're able to keep up with our waiting lists in almost all of the areas that we've got. There are a couple of exceptions, principally DEXA and echocardiography, but in nearly all the other areas we're managing to keep up our waiting lists. But the problem is that because we're now prioritising, over 90% of our patients are prioritised, as we've asked people to do, and that's the P1 to 4 criteria again. Because nearly all the patients that we have capacity for are P1, and therefore that we're scanning a P1 and P2, people who are P3 and P4 have very long waits, and that's what we're seeing. So people who need emergency imaging, emergency tests or urgent tests are being done, and we'll see in a moment the cancer targets are holding up very well. But people who are having more routine investigations are really struggling, and we recognise that. We've got quite a lot of extra capacity coming online, particularly in the MRI and CT over the next month or two, and I think that will help us. If perhaps we go on to the next slide. Well, anyway, that will help us to get down, and we're predicting to recover virtually everything by sort of early part of next year. DEXA is an issue, and we're exploring with Doddington whether some of our patients, which is up sort of Peterborough way, whether some of our patients could possibly be seen in Doddington, and whether they would be prepared to do that to help us with that. We're also looking at whether there's a way of outsourcing GP, particularly direct access ultrasound, which would enable probably a better service for GPs and for patients if we can manage to do that. So that's sort of where we are on imaging. I think it's going to be a difficult 6 months or so, but I think we are reasonably confident about most of the modalities. There are particular problems with cardiology which sort of predate the COVID pandemic actually. So we're looking at that, but that is, if we go to the next slide, that's to my mind the main outstanding issue. Endoscopy is actually again similar to imaging, has got a big is managing urgent referrals very well now, but again has a significant backlog of routine cases, but has a reasonably good recovery trajectory over the next few months. Might just be worth touching on the next slide, please, on the work that's going on with community diagnostic hubs. So this is a national initiative to develop diagnostic hubs in the community based upon the presumed further inexorable year-on-year rise in the requirement for diagnostic tests. So the CCG and the ICS have been leading some work on this, and we've had a recent workshop looking at possible locations, and this is just shows effectively the demand curve. So I think what we're looking at, or what they're looking at, is looking at how we can provide extra capacity, particularly around the sort of Fenland, Ely area, going up to Wisbech, because those seem to be the areas most in need. But obviously, the development of community diagnostic hubs, quite apart from hopefully again improving direct access, will take some pressure off the acute hospitals, which should be welcome all round. So there is, what the government has asked us to do is to get some initial, as it were, proto community diagnostic hubs in with mobile units and so on. So that's what's being looked at now, pending a more permanent solution. But it'll still be a little while, because of course a lot of the mobile capacity is being used up anyway by the reason I've just described. So we've got a mobile CT and 2 mobile MRIs just serving us at the moment. So I think although there is capacity in the independent sector for additional mobile capacity, it's not as big as you might think. And then just to touch on cancer pathways, which is the next slide. So as I said, the diagnostic side of cancer pathways has really held up pretty well. We're back up to rather above our baseline in terms of urgent referrals. We're around 75–80% in terms of the people treated within 62 days, which is just below the sort of normal targets. And the main problem limiting that being in better shape for us is 2 things really. It's tertiary referrals from other places, and it's still the constraints on surgery, which James is going to talk about, I think, in a minute. We are looking at whether that higher referral rate is important. Anecdotally, we're looking at, we're seeing what people report as, we are seeing a higher incidence of some more advanced cancers, which is what people worried about. But in fact, interestingly, the higher referral rate doesn't seem to be translating into a higher conversion rate. The conversion rate's actually come down a bit. So, I'm not quite sure what we make of that yet, but it's early days, but we are trying to keep a very close eye on it. I think that's all from me. But as everyone else, happy to take questions if there are any.
Thanks, Hugo. I think last time when we gave the update, a lot of people were sort of interested in knowing what are our most pressured services for both a new and a follow-up outpatients appointment. And I think one of your slides sort of summarises that quite nicely. And we know that sort of ophthalmology, dermatology, cardiology, and looks like, is it rheumatology as well, are particularly pressured. And I think if people want that information sent out to them, then we'll happily oblige from that perspective. Are there any other services, Hugo, that are worth mentioning?
There's a list of 20 on that slide. I'm sorry, I haven't got it in front of me at the moment. I think the ones that you've mentioned, cardiology, rheumatology, dermatology, ophthalmology, are the big ones. Christoph, are there any others on your radar?
So they're the primary ones, and they stand out quite significantly with their high risk, high volume waiting lists. Obviously, we're working with the other ones as well, and we're trying to basically optimize the room utilization. But rheumatology, for example, is trying to do this very effectively. The cardiology is coming on, and I know ophthalmology and dermatology are too. So they're the ones we need to look out for at the moment.
Yeah, and it's fair to say there's a huge amount going on in all of those specialities in terms of looking at different ways of working, virtual hubs, as well as waiting list initiatives, 6- and 7-day working, which is going on across the board in those areas. But no, and if people would like any further information on those, please contact Rachel, and we'll make sure we send that out. So okay, on that note, we'll move over into an update on surgical services from James Wheeler.
Thank you, Sarah. And I promise not to keep anybody too long because it is getting later. I don't expect you to read all of that, but just give you a little bit of a narrative of what's going on in surgery. We do cover 9 surgical specialties plus ophthalmology and then gynecology. So this very much talks to all of that. We have 37 theatres across the patch at Cambridge University Hospitals. But we're limited to 34 currently because of the fire risk for the neurosurgical theatres. And of those 34 theatres, 7.5/8 of them are emergency theatres. It gives you an idea of how many theatres we've got up and running. I probably don't need to talk to you about prioritisation scores, but the big push has certainly been the P2 type of surgery. I will come back to it a little bit in a moment, but we're going to get increasing problems with 3s and 4s, with just by virtue of being long waiters. Orthopedic capacity has been pretty difficult, and that's mainly related to inpatient bed capacity. But inpatient bed capacity and flow remains a problem for all surgical services. As Ewan quite correctly reminds me, we do have ring-fenced surgical beds now as a way of actually protecting our patients with COVID. So we are well protected and medicine doesn't flow into our beds, but the bed capacity is quite limited. And even today, I'm afraid there were elective cancer patients that were cancelled. We do keep that to an absolute minimum, but I'm afraid it does happen. Next slide, please. This slide, you may have seen similar data before, but I think it's quite encouraging, particularly if you look at the green graph, and this goes from our recovery period in early April of last year all the way to where we are currently. And there was a huge amount to learn in the first wave. You know, people were scared to touch door handles and all sorts. And you know, life has moved on a little bit, and we were governed by ignorance, lack of knowledge that we learned quite rapidly, but slowly over the course of the spring and summer. We had guidance from PHE, infection control, and we learned slowly and got up to sort of about 90% of our previous baseline. And then everything fell off a cliff in early January. But you can see that the recovery was far steeper on this occasion because we'd learned so much. And I share Ewan's hopefully joy that we won't get into this situation again. But if we do, I think our recovery can be quite quick. In terms of why we lost all that capacity, of course, our critical care facilities just became colossal and a lot of staff and equipment came out of theatres. So we are back up on some weeks at 91%, but I think the most recent week was 84%. Next graph, please. Again, this looks at theatre productivity impact. I think I'm showing you the same sort of story. If you take the red line, which is the average turnaround of cases, you know, there were all sorts of delays when we first learned and tried to recover, and you won't even notice any change in the graph this time when we recovered from the second wave for turnaround because we learned that. Cases per session, inevitably, it's the P2 long complex cancer cases that have come through. We do have list fillers, but the smaller cases aren't being done in the same way that they were previously, although Ely is a fantastic facility, and I think we've got more work to do to use that to its absolute maximum. Next slide. This is a slightly concerning graph, and of course, P2 is not something anybody knew about 20 months ago. So we don't really know what a P2 figure might have been in January 2020. Our central ops team think it's probably in the order of about 750 would be a reasonable figure. And you see it climbed up to 1700. And the P2 scoring comes from the colleges and the surgical associations. And there's been a lot of work done at a national level. We had some sort of recovery by the time the second wave came along and we're down to 1500, but it quite quickly crept up to 1700 and then dropped very quickly indeed. And that reflects the theatres getting up to maximum capacity, or the maximum capacity we've had quite quickly. But far more worrying to me now in the last month is this creeping up a number of P2s. However, I think it's pretty heterogeneous in its makeup. And I think we do have a lot of P2 patients coming through our diagnostic services, but we also have P3, P4 patients that are becoming a higher priority because they've waited for too long. And you've heard from Amanda a little bit about harm. And I suspect I do also have some colleagues in all surgical departments, so I'm not going to pick on any, who are actually moving their patients through to P2 to justify getting them through onto operating lists. And I think that's all the surgical slides, but I'm very happy to take questions.
Thanks, James. Is there? Can you just sort of highlight and discuss the plan that we have for those patients that are sort of greater than 98 weeks that have been waiting, in terms of how we prioritise them?
Well, I think that's going to be very difficult because we're going to have two masters then. We're going to have the P2 master who's out there and getting bigger, and we will have the P3, P4 central government master. And I might just bow to Ewan here for his thoughts on it.
Thanks, James. I mean, yes, this is a difficult challenge, but there's no doubt that there will be political pressure to avoid very long waits. And of course, it's important for patients. I mean, we probably couldn't have imagined patients waiting 98 weeks before the pandemic. We have a particular challenge. James said we've got 3 theatres closed, which does make it difficult to truly maximise the work. I know James and his teams are doing lots of work to make sure that we get as much activity through all of our theatres, including the ones up at Ely, as possible. And we're certainly having a lot of discussions with North West Anglia for those situations where, for example, in trauma and orthopaedics, where we have a particularly large, long waiting problem, much greater than that in the north of the county, and we're working out how we can perhaps even out some of those waits. Lots of work. It's a not insignificant challenge, and of course, you will end up then with patients, potentially with P3 and other P4 patients, all waiting very, very long periods of time. So we're going to need to work really carefully to try and get the balance of all that right.
Okay, thank you. Are there any comments for James from anyone else on the panel? I don't think there's any other questions that I can see. If that's the case, we've got quite a quiet audience tonight, but obviously if there are other sort of questions and things that everyone's stunned, I think, by last night's football. So if there are any other questions or anything that people have, please feel free to send them in. It's really, really great to hear your reflections, and a lot of the stuff that we have brought into the presentations this evening were based on a lot of the feedback that we had from the last two, the previous discussions that we had with everybody. And I think at the end of this, Rachel's going to be in touch with you with a short questionnaire to find out what you thought was helpful, maybe what wasn't helpful, and also what we haven't covered that people would like covered for future events. And so I think, Rachel, you're gonna send that out. And equally, there's a slide at the end that Rachel's put together with useful contacts, and that will be sent out. And I think there's also going to be a link onto our Connect website, isn't there, Rachel, for people to access the slides after the evening tonight. Is that correct, Rachel?
Yeah, absolutely. So that will be on GP Connect from tomorrow morning, so you can watch the recording and also access the slide pack as well. And as Sarah says, we'll be sending round a survey to all those that have registered for the event to inform future events ultimately.
That's great, thank you. Yeah, go for it.
Could I just thank everyone involved on behalf of the GP community for the time and effort in putting this together this evening. It's enormously reassuring to know what is going on and to be able to share that and explain that to patients, that transparency on the data is really, really important and really helpful for all of us. And also an enormous thank you to colleagues within the CUH Trust for everything that you are collectively and individually doing for our patients. It is enormously appreciated. We understand the pressures that you're facing and the difficulty in trying to meet demand in an unprecedented situation. And I think evenings like this and the fact that actually we're having these discussions is just an enormously reassuring component of building trust relationships, a shared understanding and a shared future together as we move towards an integrated care system and the delivery of ever greater integration of services between primary, secondary, acute and community, charitable and voluntary sector. So thank you very much indeed.
Thanks, James. And I think, we reiterate it back to yourself, and also our primary care colleagues are also on the line. And I think, as we move forward, it would be great to be, really working on those patient pathways and unifying and streamlining the processes to prevent any sort of duplication and really supporting each other across the system, really, isn't it? So on that note, I think thank you to everyone for spending your evening with us, and thank you to all of our speakers and for everyone joining us. I think there's one last question in there. Fantastic. Thank you very much, Michelle. And as I said, if there's anything you want to feedback after tonight, then please feel free to. So on that note, I think I'll close the session for tonight. So thank you.